Good morning. All right, why don't we begin? Today we have a very special speaker and a very special lectureship. Today is the Burson Yalow Memorial Lectureship, which is awarded to the physician scientist and researcher who embodies the extraordinary investigative spirit and selflessness of its namesakes, Dr. Solomon Burson and Dr. Rosalind Yalow. The award began in 1980 as the Solomon A. Burson Lecture in recognition of his groundbreaking work in clinical biochemistry and his years of dedication to Mount Sinai Hospital. In collaboration with Dr. Rosalind Yalow, Dr. Burson helped develop a number of groundbreaking antigen assays for various hormones, including insulin, parathyroid hormone, ACTH, and growth hormones. Their work formed the foundation of modern nuclear medicine. In 2022, the department renamed the award the Burson Yalow Memorial Lectureship in recognition of Dr. Yalow's equally significant contributions. It should be noted that neither scientist patented these processes nor profited commercially from their medical and scientific breakthroughs. Dr. Burson later served as chair of the Department of Medicine at Mount Sinai Hospital from 1968 to 1972. In 1977, after Dr. Burson's passing, Dr. Yalow received the Nobel Prize for their joint work. And now to introduce our speaker, I'd like to invite Nate, one of our chief residents.
Good morning, everyone. As part of the Department of Medicine Research Day and Burson Yalow Memorial Lectureship, I have the distinct pleasure in introducing Dr. Cairns as our Grand Round speaker. Dr. Cairns is the Dean of the College of Medicine and Senior Vice President of Drexel Health at Drexel University. He's a graduate of Dartmouth College and received his medical degree from the University of North Carolina. He completed his residency in emergency medicine and fellowship in the cardiovascular research at the Harbor UCLA Medical Center. Dr. Cairns has established himself as a leader in emergency medicine and critical care education, training, and research. He has been leading Drexel through a partnership with St. Christopher's Health for Children and the establishment of new regional medical campuses in Pennsylvania, California, North Carolina, New Jersey, and Delaware, as well as the opening of a new four-year regional medical campus with Tower Health in West Reading. These efforts have resulted in Drexel becoming the largest private allopathic medical school in the United States, with record student applications, student enrollment, and extramural research funding. Additional achievements include leading the University of Arizona College of Medicine through a $1.2 billion merger with Banner Health, which resulted in one of the largest nonprofit health systems in the United States. Serving as the Chief of Emergency Medicine and Director of Emergency Medicine Research at Duke University and the Duke Clinical Research Institute, the world's largest academic clinical research organization. From a research perspective, he has published over 200 scientific articles and reviews and secured more than $40 million in research funding. More recently, he has been leading COVID-19 research and innovation efforts as a clinical lead for the NIAID COVID-19 immunophenotyping impact study as a principal investigator of the Bill and Melinda Gates Foundation project on the prediction of COVID-19 community infection and recovery. He has also been awarded the John Marks Leadership Award from the Society for Academic Emergency Medicine, the highest award in the field. Please join me in welcoming Dr. Cairns.
Well, thank you so much, Nate, and frankly, thank you all. What a privilege and honor it is to be here, be part of such a distinguished lecture series following the steps of Nobelists, and I really appreciate the biochemistry component as we go through our talk. I am going to need help in just how to advance the slides. No, I got it. Thank you. All right, so I think no particular relevant disclosures here. The objectives I'm going to talk about today is how to put this in a broader context. So I'm going to talk a little bit about population health. So we're going to go from emergency care to critical care to population health. I'm going to introduce this concept of precision medicine, which you all know and live. Mount Sinai, frankly, has been a world leader in this. I'm going to talk about how we do this practically across individual patients to large populations. and what the intersection of this might be, especially in the age of the digital transformation. But I'm going to start off with a case. So I always start off grand rounds and lectureships with a case. So I'm going to start with a 12-year-old male. Came in during the spring with fever, vomiting, and lower extremity aches.
We can click on the, see, it's possible to click off the OK. Like there's like, I don't know where that would be on your.
It's only when we think technology is our friend.
Is anyone more tech savvy than I am that could find the OK?
There's always a chief resident.
I know. It's like, find how to, just so we can see the tops of the slides. Oh, there we go.
No.
I don't know, he took off. I would propose we go ahead, and if somebody has a question about the top of the slides, they can ask me. And I could do it without slides, but I've got some cool pictures, so I want to get to those. How's that? So, 12-year-old male comes in the spring with fever, vomiting, lower extremity pain, goes to his primary care physician's office, heart rate's 140, respiratory rate 36, temperature 102. Primary physician says could be strep, did a strep test negative. Sent to the emergency department for rehydration for suspected viral gastroenteritis. And the emergency department had a heart rate of 131, respiratory rate 22, temperature 38.8, and pretty good pulse oximetry. He's given 2 liters of fluid, given an antiemetic. After treatment, he was improved, sent home. Diagnosis flu. Of course, this is a grand round, so there's going to be follow-up. So the follow-up is he had an episode of diarrhea, but he felt better afterwards. Next day, his parents called his primary care physician twice for advice. He was prescribed Motrin and Tylenol, along with fluids and crackers. But then his parents noticed that the area around his nose had become blue, and his toes were cold. He was brought back to the emergency department. He was hypotensive, tachycardic, hypoxic, evidence disseminated, intravascular coagulation. Intubated, sent to the intensive care unit, died 2 days later. Complications of sepsis. In the emergency department, they looked and saw that he had a white blood cell count of 14,000, 53% bands the day before. This is the case of Rory Stoughton. And I suspect many of you are familiar with this. This was reported in the New York Times. His parents, whom I got to know very well, started the Rory Stoughton Foundation. This was really to take on the challenge of sepsis and early recognition of sepsis. And when you have a case, I want to be sure we cover the bases for our students, our interns, our residents. And we know a lot about sepsis pathobiology. We know that there are pathogen factors with viruses and bacteria, fungi. It's a case where the chemical reaction to the pathogen is the problem, with excessive inflammation, impaired immunity, microvascular injury, leading to organ failure, and there can be host-modifying factors, including age. There's a wonderful review of sepsis in the December issue of the New England Journal. We also know that there are interventions that can make a difference. So the idea of bundles and bundling care are key. So I'll just quickly review these. This is an article from The Lancet. It could be any number of systemic reviews. But the idea is you measure lactate, get an idea of what the metabolic state of the patient is, that you get blood cultures. That you get these blood cultures before you give antibiotics is an optimal practice. That you get 2 blood cultures. If the patient is not having shock or low blood pressure, then you go ahead and get the antibiotics within 3 hours. If they do have shock, it's within 1 hour. And then the idea is to give fluid bolus if they have shock. And if you follow these things, on this graph, you'll see on the right side, the blue lines are associated with reduced mortality. And interesting, the bundles themselves weren't. But overall, we know that we've made a difference in the mortality of shock. So here's an example of one of these studies. The blue got the plan with the lactate, the antibiotics, the blood cultures, the fluids, and the red is where it wasn't. But there's a challenge to this paradigm. This is now what the mortality has been in shock following these approaches over time. And this was from a good colleague of mine who was up at the Mayo Clinic, was part of the US Critical Illness Injury Trials Group when I was director. And he pointed out that while we made much progress, we really haven't changed much. And you could extend that out to 2025. People are starting to ask then, not only just, we're not making much progress, but we've been spending a lot more money. And now I'm going to take a macro view of what this looks like for the US economy. So on this graph, on the vertical axis, we have healthcare expenditures per capita. And on the horizontal axis, we have life expectancy at birth. This is for a bunch of countries. And if you take a look at where we are, the United States is, of course, way up at the top. And you see that's interesting. Number one, we're higher than any other country in our expenditures. But look at many countries are over to the right of us in terms of life expectancy. One of those countries is Cuba. So we're spending a lot of money, haven't made a bunch of difference, at least in sepsis, leading cause of death in children, leading cause of death in hospitalized patients, and people aren't living longer. So I have a question for you. What is the percentage of the US economy that's dedicated to healthcare? Is it 10%? 20%? 25%? People haven't had their coffee yet? Okay. 25%. Close. 20%. It's the single largest sector in our economy. Pretty amazing when you think about it. Another way to look at this is, where are the costs going to go? On that graph, you saw them going up. Well, I can tell you, Roy Stone's case, while it's really impressive as a 12-year-old, you should realize that we're becoming more and more aged as a society. In fact, the graph on the left suggests that by 2030, this is from the US Census, there will be more people over the age of 65 than children under the age of 18. Hence the topic for medicine grand rounds. And if you take a look at another way, what this demographic shift means is on the left in 1960, that was the makeup. As you can see, it's really it's a pyramid with many more children than folks who are over 65. It's now literally become a pillar. And it's estimated that over 30% of the population just in the next 20 years is going to be over the age of 65. So this brings up this idea of population management. So the idea here is that we're really moving to a paradigm where we've got to think about these costs. We've got to manage populations. And I'm going to get back to precision medicine as potentially a strategy on how to do that. But the idea for this, and I'm not going to go through this, it's subject of much discussion and policies, but we go from volume-based care, reactive care, taking care of patients in emergency departments, to prevention, being proactive, and thinking about the value of the costs of these interventions. Lots of comments on what this might be called, health reform, the affordability gap. For a family of four now, it's more expensive to pay for health insurance than they can possibly afford. The FAAEM I'm going to introduce, and the weight of the nation, single biggest sector in the economy. And there's been a lot of discussion about reimbursement. And the current administration is very concerned about cost transparency. So people are going to start looking at all the costs of these early interventions, cost of ICU care, cost of emergency department care as we move forward. This FAAEM, I brought this back up. This is from the Institute for Healthcare Improvement. I still think, independent of what happens towards federal healthcare, that people are going to ask, what are we getting for all these costs? So I'm just going to highlight population health, patient experience as that kind of like expectancy. And then the costs, of course, per capita costs. And you saw where we are compared to every other country in the world. Okay. So I did mention that sepsis is the leading cause of death in pediatric patients. If you look worldwide, or better yet, ask Google, is sepsis the leading cause of death in children? Yes. 3.4 million children per year. Relevant to our medicine grand rounds, is sepsis the leading cause of death in hospitalized patients? Yes. So here's something where mortality directly intersects with our healthcare system and costs. Yet, why haven't we made any progress for the last 10 years? Well, the first thing I'm going to introduce is the idea of sepsis clinical trials. There have been a number of them. You may have participated in them. I know that you read about them in Journal Club because there are just so many of these that have been done. We know that sepsis is really a clinical syndrome, that there's a lot of heterogeneity because of that, and that there are multiple different factors in clinical trials that could lead to failure that may have nothing to do with the understanding of the mechanism and the targeting of the therapy towards that mechanism. I'm going to say it's due to the fact that we haven't hit the right patient at the right time. And so this idea of stratification in clinical trials has not been performed, mainly because there have been difficulty in terms of classifying patients. And I'm going to propose a precision approach to maybe get around this problem for, again, the leading cause of death in children, leading cause of death of adults and hospitalized patients. In fact, in that same review from the New England Journal by Meyer and Prescott, they highlighted all the challenges of these sepsis trials. But I'm going to highlight three. The first one was the FRESH trial. And it was an interesting trial in that there was some statistical difference, but it was really kind of looking at change in stroke volume after passive leg raise, right? So just putting people in a different position. The other ones were classic and Clovers, and I was part of Clovers. It's the prevention and early treatment of acute lung injury, the PEDAL network, and I sit on their protocol review committee. And we didn't see a difference in mortality. But similar to the FRESH trial, we found that a personalized approach would be the way to go. So the idea of this personalized precision approach is showing up in clinical trials as well. So why might this be? So I'm in emergency medicine. So we intersect across multiple different fields. So I intersect across infection and sepsis, injury and trauma, burn, and looking at this response to stress cases with the immune response. So imagine a graph on the vertical axis, immune function. Imagine the horizontal axis being time. And I want you to imagine for all of these conditions, there's an initial insult, and we're going to look what happens in inflammation over time. So imagine that you have an anti-inflammatory drug. Let's say that drug is steroids. And you give it during this pro-inflammatory phase, you actually have a chance of taking on the mechanism for which the drug was intended. But the very same patient at the very same setting with the very same condition, if you catch them at the anti-inflammatory phase, then this drug could do a great deal of harm. So if you don't account for that in time and don't recognize the severity and where you are, you may be missing not only the target, you may actually be causing more harm. So our first attempt to take on this challenge involved looking at biochemical pathways. So that's why it's a real pleasure to be here. So I'm sure everybody knows what this is. What's in the middle of the, people had enough coffee now to at least answer. Yeah, TCA cycle, Krebs cycle, citric acid cycle. We're gonna go ahead and measure all this. So this was our first big data approach, and it was done in conjunction with the National Center for Genomic Resources. And it took a lot of supercomputers to start taking a look at these data. But what we were able to determine was that we could distinguish those who had inflammation, the systemic inflammation response, or the SIRS syndrome, who weren't infected, from those who had inflammation and were infected. And in fact, we could distinguish potentially between bacteria and viral disease. The second thing we were able to do is we were able to take a look at all those metabolites and then look at the relationship to proteins. So the proteins are going to be changing inside the cells, so the structure of the cells being fundamentally changed by this metabolic response. And when you do that, you start to find pathways that are intersecting that are very interesting. Now, this one on the lower right, many in the faculty here will recognize the nitric oxide synthase pathway. This has been a much discussion, and there have been therapeutic targets against it. What we found interesting were some of the fatty acids, one acetyl-CoA synthetase, and we are now starting to design therapies for that. But it was very interesting when we took a look at whether or not this approach could actually help predict who's going to live or die then. Taking on that issue of who needs early intervention, who needs high resources, taking on Roy Stanton's problem, maybe on day one. So in this study of 1,200 patients, all at the very first point of intersection with the healthcare system, many in the emergency department, we were able to make a diagnostic distinction. So these are receiver operator graphs. So on the left side, you have sensitivity on the vertical axis, 1 minus specificity. On the horizontal axis, a perfect test would be way up there in the upper left-hand side, 100% sensitive, 100% specific. When you use clinical criteria alone in terms of organ stratification systems, on the left, you get an area under curve of 0.66. I was going through the posters yesterday. There were a number of you that had receiver operator curves with areas right around 0.7. I accept that as a good clinical test. When you add the discovery metabolomics and 9 select of those numbers, we get areas under the curve of 0.93. And so we're starting to get upper 90s of sensitivity and specificity. In fact, in subsequent papers, we were able to show we can distinguish viral disease from bacterial disease, with the obvious implication being that bacterial disease is going to need antibiotics sooner and targeted that antibiotic treatment to the appropriate organism. So the idea here on the left side is that the bacteria, look at the bottom graph on the left, you see the bacterial side distinguishing from viral. In the viral column in the middle, the viral from bacterial. And by the way, NI is not infected. And then when you go to the non-infected, you see it distinguishes from viral bacterial. And that has been interesting to think about how we might start tailoring people and even point of care. I was going to talk a little bit about the impact study, Nate, so thanks for bringing it up. This was the big National Institutes of Health study of hospitalized patients. Mount Sinai was part of this study. And we looked at hospitalized patients and followed just about every bit of big science you could do beyond even metabolomics and proteomics. And so we looked at blood, serum, plasma, nasal swabs. We looked at metabolism. We looked at genetic expression. We looked at whole genome sequencing. We looked at proteomics. And we were able to do some interesting things. The first one in the upper left-hand side is that we could distinguish, using a machine learning approach, an analysis of all these things, which patients were going to die. That's the upper red. We could then distinguish those who were going to go home. That's the green. And then we could predict the hospital severity course of those who are going to require oxygen, those who require ICU care, and those are the middle ones. And you can imagine the ICU is the more orange color. So that was from a first baseline sample, but it took a lot of analysis. The other thing we were able to look at are some really interesting concepts like about aging. Remember, the aging shift in our population remain. Aging is a host response we know is challenging in sepsis. This is a paper that our group published, and it really is amazing what big science can do. And I'm really appreciative of NIAID for putting these kinds of resources, and really grateful to my Mount Sinai colleagues who helped make this happen. If you take a look at the right-hand side of the graph, this is going to be the change in aging response across multiple key components of the immune system, going from monocytes to CD8 cells, CD4 cells, B cells. And on the right side of this is the immune response that's increased in age. That's in the red boxes. On the left side is the immune response in blue, decreased with age. And we can now do a quantitative calculation based on year. So now we're going to get closer to this kind of personalized approach by now being able to select out what an immune response is year by year. But what about an individual patient? As part of the impact study, and these are data from our group and an MD PhD student of ours who's been working with a mentor who's been looking at glycosylation. So this is glycosylation occurs in IgG. It's well established. It helps antibodies configure to their pathogens. And therefore, it's a suggestion of pathogen-specific responses. and allows it a different contortion. People hadn't looked at IgM, which is the initial response, which is what you would capture really early in the course of infection, and therefore might be really valuable in emergency or acute settings to help distinguish. And it turns out when you do this, you can determine who's going to have severe or non-severe disease and those in early infection with, in this case, COVID. So now we're getting to the point where we might be able to take an individual's response to that infection and determine whether or not they're going to have severe disease. So this brings up this idea, and I'm going to call it precision emergency medicine, because I've been talking about acute disease, initial assessments, but I think it could relate to all of medicine. So what's the idea here? And Stephen Kingsmore, one of my colleagues from that large metabolomic study, who's now at Rady Children's Hospital, I took this from his slides. So think about getting on the right disease, the right subtype, the right drug, the right patient, the right dose, right duration, right? So we've got the right patient characteristics. We know it's a bacterial disease. We now know it's what the cause of that bacterial pathogen is, and we know the antibiotic. But I'm going to add, we need to be interventional, right time, right place, and you already heard my comment about right cost. What about the age of computing? Well, how many people here are using AI? I'm going to say that's a good 70%. These are the data from the latest AMA survey of physicians on AI, and 68% of the physicians surveyed now say that AI is a help in their practice. In fact, of this survey, there were some key insights obtained. First one is that physicians are becoming more positive about AI. And this is up significantly over the past couple of years. That there's been a substantial growth, and so the numbers in this room reflect the national, up to 66. That really it's being used for administrative purposes right now. Things that are helpful in terms of managing patient lists, things that are helpful in terms of being able to figure out how to take ambient listening and turn it into electronic record. But in order to use it for decision-making, one thing became clear, is that physicians have to build trust in these tools. And there needs to be more regulatory insight. So the basic question I'm going to pose back to sepsis is, can we use AI to help us with these enormous data sets, take on this problem of complexity now that we have all this knowledge that's specific to infection, specific to pathogen, specific to age, and the individual host response? Well, the first one is, I think these need to be assessed clinically. This is an article from my colleagues at Duke and UNC that were published last year in Nature, and basically it showed that there are a number of AI devices that have been approved by the FDA. The challenge is the most are missing clinical validation. And I think it's something we're going to have to, as physicians, physician scientists, and scientists, take a look at how these tools are being validated. But there is an FDA-authorized an artificial intelligence machine learning tool now for the prediction of sepsis. And this came out late last year. Nate Shapiro from the BI and Harvard is the senior author. And I think it's interesting when you start looking at what this tool does. The first one is, and yes, now we are in trouble about not being able to see the upper part. So I'll just tell you what it is. So the first one is ICU transfer. And you could see that the green is low. If you're low risk in the tool, very few of those patients go to the ICU. On the far right is red. You have a very high chance of going to the ICU. In fact, that same thing holds true for in-hospital mortality. That's the second one. Or the need for ventilation. That's the third one on the upper row. Or let's go to specific interventions. Vasopressors on the left side, and even length of stay, the research metric. So this seems to predict fairly well. I haven't used the tool. I do have experience, though, in developing dashboards for how we might look at these kinds of data. And this came out of the COVID experience, and we had a large consortium in Philadelphia, and I do appreciate the sponsorship of the Bill and Melinda Gates Foundation, as we decided to start seeing we could use probabilities, machine learnings in a dashboard, real time, and manage a population, in this case of 50,000 people. What we were able to do is to take a look during the pandemic, and you recall there were a number of different variants. There were a number of developments. We got testing first, then we got vaccination, and then we could start looking at breakthrough cases on the intersection of that over time. And this allowed us to have a fairly robust longitudinal perspective on how a system might work. So one of the things we were able to do is to figure out the different symptoms. And if you recall at the beginning of the pandemic, we weren't sure about some of the symptoms. Think about conjunctivitis, right? And then the loss of taste and how all these things started coming out. But we knew in big populations that many patients had no symptoms. And that became a big challenge for population management. So this is what we were able to do in our dashboard. I'll just show a screenshot. Because we had a large population, including students, we could take a student at a time of testing, in this case, a male student who was vaccinated, had no symptoms, and predict after a negative test what their chance of being positive in 2 weeks were going to be. And we needed that because we had to determine the frequency of testing. And 7.2% at this point in time in the pandemic. Take the same student, not vaccinated, and was now a 39.7% risk. I mean, we all know vaccinations work, but here's proof. Even though the vaccination efficacy went down over time, it was pretty interesting that even patients without symptoms, we were able to detect what was going on. How do you do this? There are lots of ways to think about artificial intelligence. You have some world experts in artificial intelligence at Mount Sinai. You really are at the cutting edge. There are many ways to do this, but this gives you an idea of what a forest tree looks like. You start off with patients, are you vaccinated? You then determine what the risk factors are, the different colors, determine what the dichotomies will be. In this case, students 21 years or older, 31 years or older, and you could start getting this system to be a feedback loop, and it learns as more and more data come into it. The other key thing we recognized is that knowledge in the COVID-19 host response was expanding. It was expanding at an extraordinary rate. So this is now this concept of a knowledge graph. So a knowledge graph is going to link all the data that are out in the world to specific connections across diseases. In our case, we've been working on doing this in data that we have verified through PubMed and then utilize as a tool. What does this look like? Well, first of all, think about sepsis, back to sepsis, as part of a communicable disease. When you start going into these knowledge graphs, you can start honing in on things like the systemic inflammatory response syndrome. When you keep going down, you can start to determine those with viral infections versus those with bacterial infections. Let's go to another part of this knowledge graph. Fever, right? Because Rory presented with fever. And you could start getting linkages to bacteremia and systemic response. What about determining what the severity will be? Well, you can go from bacterial infections to those with sepsis to those with septic shock. So now being able to link all of those data, including international guidelines, and our students built an international guideline-based virtual 911 system for the world. It's interesting. That could be used in any language and can be used on cellular networks in addition to the internet, and actually can be used just doing text. That's where the technology is right now. But imagine linking all the data in the world to vetted data in the world, trusted data in the world, to all the data in a patient database. And all our medical students at Drexel now are trained in large databases, 200 million patient data sets. They learn how to use dashboards so they can look at individual responses to treatments, and we have propensity scoring so they can take a look at how that might compare. Now, they aren't using it clinically, but they are taking it around on the wards. And so imagine being able to do this then at a point of care test. So the question comes up, will AI replace doctors and teachers? Well, Bill Gates on the Tonight Show in February said that AI will replace doctors and teachers within 10 years and claims humans won't be needed, quote, for most things. If you listen to what he said, though, he said computing has basically become free. That intelligence will become free and commonplace. That this could solve the problem of not having enough doctors. And that indeed we won't need humans for most things, but that allows humans to concentrate on things that we have the most value of. And then one of these areas would be the ability to improve health and diseases. I think the other interesting quote was from last Sunday's 60 Minutes, where they had Dimas Habassis, who won the Nobel Prize for using AI to get the structure of proteins. And one of the things that he did, it taken like 10 years to get the structure of some of these proteins using conventional programs. He now has one where they had 200 million proteins in 1 year. That'll give you the power when you use AI. But he's also the head of Google DeepMind. And in his interview, he said, we can cure all diseases with the help of AI. And then when asked what the time frame would be, he said, maybe within the next decade or so, quote, I don't see why not. I just find it interesting that both Gates and Habassis say the same time frame of 10 years. So, will they replace doctors and teachers? Well, there may be some caveats. This is a poster from one of our medical students in conjunction with one of our faculty. It was at our research day this year. And they were looking at what's the impact of ChatGPT on kind of an educational question. The question was, can AI identify the bones of the foot and help with anatomy? So let's focus in on the middle part of this slide and let's count the metatarsals. 1, this is an AI generated image of the foot. 2, 3, 4. Where's the 5th? Okay, let's reverse the question. Let's ask AI to identify the bones inside an image. So this is on the lower part. So when you do kind of a pencil line drawing, AI got 27% of the bones right. If you add a little color and texture to it, you get up to 57%. What about an actual X-ray? Something we think will be kind of important in our clinical decision-making. 0%. So clearly, there are challenges to the use of AI. And they conclude that you need to know the purpose of using the AI, that you need to understand your own knowledge level and how to compare it to what the output is. That you've got to look at that output then in context of your knowledge and how you're going to apply it. And you've got to get the right balance between humans and machines. So another way to think of it is that we need to be the key component of AI. And I think this illustrates the reason. But what a pleasure it has been to be here. I think I'll just conclude by saying emergency care saves lives. I'm going to extend that to medicine. I've had the privilege and honor of serving in the Department of Medicine at 3 of the institutions I've been at. Starting on my first academic appointment was in the Department of Medicine at UCLA. It's in the Department of Medicine and Surgery at Duke, and now both medicine and emergency medicine at Drexel. But we do need to provide more efficient and cost-effective care in the context of population management. We're spending a lot of money. People are asking, what's the output? And we're so much higher than every other part of the world. We do have the tools now to precisely define the individual response. And they may not be perfect, but they're getting very good. And we can then look at these responses to acute infections. I'll extend that to injuries, and I'll extend that to ischemia. We also have the ability to have real-time access to these really large databases. Artificial intelligence isn't here, it's just accelerating at an extraordinary rate. And there may be opportunities for us to use machine learning as we try to take on individuals within this broad population. But I think clinicians should be directly involved in identifying the artificial intelligence use cases. I think we need to demand that the medical data and outputs are indeed trustworthy. And the only way for that to happen is with us all collectively to be an expert in our spaces. Find your passion of clinical care, of research, of education, of knowledge translation to patients. Be an active, engaged, and informed user of AI. I saw that 70% of the people in this room are using AI. I just encourage everyone to test it out because it's a very experiential thing. But in all honesty, I think it's important to attend a conference, a meeting, or a course on AI. I formerly took courses at MIT because I really wanted to know how these things were working and what the context might be. And frankly, it got me back to coding. I know the young folks here, but I separated myself from coding for a good 10 years. And it's actually fun to get back to it when you have an AI assistant. And then this idea, Vivian Lee says, of co-producing. This is the idea that we work together as providers and computer scientists, as clinicians and those doing basic research to come up with the best solutions. And I think that's a really valuable opportunity with AI for us to start doing this. Let's co-produce the solutions we want. And the reason is to be most effective for our patients, for our populations, and frankly, the future generations. So with that, thank you yet again for the opportunity to be here. I'm so impressed by Mount Sinai, everyone I've met here, privilege and honor to serve as your lecturer today.
Thank you for sharing your time with us, your knowledge, and for this phenomenal talk. And before we move on to Q&A portion, I'd like to present Dr. Cairns with a plaque as our honorary speaker today. Thank you so much. Thank you so much. And I'd like to open up the room and Zoom for any questions.
Thanks for that wonderful lecture. I'm struck by the issues that you brought up with regards to the cost of medicine, but also with the genomics approaches that you took, these deep dives into deep data, they're also very expensive. And with regards to how do you take the depth of the analysis that you do, how can that be applied for cost-effective diagnoses in the models that you do?
No, really, thank you for that question. And I think, the question was, these things are expensive. I'll try to give a longitudinal answer. When we were first doing those metabolomic studies and the proteomic studies, those are systematic approaches. That's really, for those days, that was really big data. This is going to be circa 2012. I wasn't kidding when I said we needed 3 Cray supercomputers running in parallel to run the analysis. And that's why we needed the National Center for Genomic Resources to run it. It's in Santa Fe and, uses things from Los Alamos. These analyses we've been doing recently, we could do on our laptops. But we don't even have to do that anymore because we can use it in the cloud and have these tools out in the cloud. So the cost of computing per Bill Gates has come down so substantially in the last 15 years that I think we're going to have an opportunity to make this real. But your concerns are valid. And the other side of it, of course, is how much is AI costing us? And it's fascinating. We had some discussions yesterday. What's the power needed to run these computers? And you should know that Bill Gates has been investing in nuclear power. And the idea of having these dedicated nuclear power sources in order to run these computers, it's kind of an extraordinary concept. And we were talking about this yesterday. I mean, I remember 3 Mile Island, and there were a lot of consequences after that. And certainly we saw Chernobyl. So I think we just need to understand how we're going to use that power source. But it certainly would be one potential solution. I think the second one is the idea of quantum computing. And everyone talks about it. My nephew works in an area intersecting with quantum computing, and they're moving very fast. And at some point, it's going to come into play. And that is thought to be the key driver of artificial generalized intelligence. And if that happens, then all those timeframes that we talked about will be accelerated even faster. And it should make it cheaper. But then the last piece is, it's already expensive. Are these going to be tools in the hands of clinicians? Will we be able to use it in low resource environments? because that's where the burden of disease is. Most of these children dying of sepsis are outside of the United States. Will they have access to technology? And I think that will be the opportunity with AI, but only if we as a society, we frankly as physicians and leaders drive it towards that. Otherwise, I am concerned that some of these AI solutions could become enterprise-based, proprietary, and extraordinarily expensive. So all the models that we're developing for our large language models, we're using open source tools. I assume Mount Sinai has AI tools available on your enterprise system now. Many systems use Microsoft. Many systems use things like Copilot. Those are closed proprietary systems. Did I answer your question? Dr. Kraft.
You think I would know all these data, but I don't. So it was fun to hear, so thank you. I was intrigued by the area of the curve analysis you have for sepsis mortality and metabolites. So fast forward, because that was a couple of years ago, is that something that we can think about clinically available tests, add to our clinical indices and add those? And is that being developed in any way? Because it just seemed like it really do a good job of predicting mortality.
No, thank you for the question. Indeed, those tests, so the distinguishing features, the metabolomics, ended up being part of a DARPA project. And so DARPA has been developing that for a host response test in the settings of true protection. And I should say that that test and that approach was used in the pandemic by a number of groups. One I'm familiar with is BioMe, and to distinguish on the host response. The analysis of the classifier is a subject of much discussions. That's been assigned to Duke University, and that's being assigned to proprietary interest. I don't know those because it's university assigned patent. And the last one is, can we do this analysis in a quick way? That's been the subject of another DARPA-related project, is how do you make like a mass spec in a can? And I can tell you that has now gone to the point where it's possible. It's being utilized. But like all these questions similar to yours, when is that going to become accessible? When's it going to become affordable? But certainly I think it could be impactful. I hope I answered your question. And by the way, that signature, I didn't mention this, was replicated in severely injured trauma patients who develop multi-organ failure. So there's something fundamental about that metabolic signature. Yeah.
Wonderful talk. So I'm really interested about this immunotherapy for the sepsis patients. So have you found any gene related to the innate immune system which might be affected patient most susceptible to sepsis? You described IgM, but I wonder if there's another innate immune system showing the host response. That's what
Yeah.
more important.
Well, I don't disagree. Well, I'm going to say the first response that we definitely wanted to jump in on. Now I'm going to go back to Rory Stanton's case, right? There were a lot of signs there, right? The tachycardia was there, the fever was there. It turned out the white blood cell count with a shift in bands was not noticed. So there were typical clinical signs, but there wasn't a lactate. I would say that the metabolic response is the immediate one, just because it's the immediate one of this derangement, which seems to be so predictive of death. But I don't disagree with you on taking a look at the early immune response and that structure between proteins, right? And whether they're in the forms of antibodies or in the forms of, C-reactive protein, or whether they're in the form of procalcitonin, and some things that are clinically accessible. But obviously, some of the things that we're bringing in here aren't currently clinically accessible. And the idea is to identify those that could be brought in a portable, time-sensitive, let's face, cost-effective device. Because again, this is the leading cause of death of children worldwide. This is the leading cause of death in a hospitalized patient. It's worthy of our attention as long as we understand we have to be efficient and effective in a precise approach of using them. Did I answer your question? Yeah. Oh, by the way, the whole genome analysis, that's been tricky. It's been very tricky to determine on whole genome analysis, and I think we just suffer a little bit from not having quite a big enough sample size. We see some distinction, but Monica, I'm not aware of any particular whole genome analysis so far from impact that's identified something distinctive.
And the innate immune system?
And the innate immune system. And these are all expression analyses that I showed you today. Yes?
So I think since I've been in cognitive medicine, the big thing going on was big data with EMR and now you've been at the forefront of all of this expanding innovation. What do you think in 20 years we're going to be talking about?
I think we're going to be talking about how to help people live the best, longest, and happiest lives. And I use that word happy because I think that productivity is going to change so dramatically based on a lot of this AI, that things that we use a lot of physical time, energy that we wouldn't consider to be priorities are going to go away. As I was going through the posters yesterday, I found it so amazing. The robot was sitting there cleaning the floors. It was persistent in terms of tracking between. It certainly didn't stop. And it just kind of reminds me of what I think the future might look like. I think there'll be a lot of these things going on autonomously. And I think in ways that we can't imagine. What do I think it means for physicians? AI is not going to replace physicians. But I was at a big global consortium meeting on this topic a couple weeks ago. And the best answer I heard was that physicians who use AI will replace physicians who don't. So in 20 years, everything I just brought up is just going to be like something that is just accepted. It's like, think about source code of the internet. Nobody uses it. I was involved in building the first website at the University of Colorado in 1991. And, we had to individually code all those links and link it across, to Mosaic in the supercomputer in Illinois. And you don't even think about that when you do a search now, right? I think it'll be the same thing in the next phase. In 20 years, for sure. But I hope you all are there to take care of me. How's that? Yes.
Yeah, really great talk. The Rory Stanton case turned New York State's approach to sepsis upside down. Because the New York State Department of Health came in and said, we must do things this way. And so we've been using the bundle now for 15 every year, and we do it reasonably well. Not 100% all the time, but we do it reasonably well. And we're stuck. We haven't gotten better in, I don't know, maybe 6 or 7 years. I'm just curious if you're doing anything at all at Drexel that making you a little better than the rest of us and what that is.
No, I think the world is pretty reflective of that graph. And that's why I showed that graph of sepsis mortality flattening out. There was an improvement. There was an improvement. And, when you talk to Sarah Stanton, he was pretty adamant about getting that law passed, and obviously had Chuck Schumer and many others who were behind him, and that's why that legislation came into place. And that became, by the way, a national, if not global standard. So New York was ahead of that. But yeah, I think I don't have any particular insights what we're doing clinically, but I'm going to give you my insights as to why we're not doing better. I was on the Protocol Review Committee, as I said, for the PEDAL network, and that was one of the studies, Clovers. And I kept pushing them to do more defined phenotyping and do stratification, and it didn't happen. And I was involved with another large NIH trial that showed that the fluid bolus couldn't be prescribed to make a difference. But when you look overall, the mortality in the overall study was so much better than any historical previous one that there was a huge confounder. And the biggest confounder beyond that historical one, and everyone was influenced by the bundle movement, was the fact that the amount of fluid be given varied from 500 to 2,000 milliliters. So if we're precise, we can define the host response, we can define the metabolic derangement, we can tailor those fluids to that at an early time, then I think you can make a difference. I've monitored patients directly with near-infrared spectroscopy using a device where we can measure brain oxygenation, we can measure cytochrome A3 redox state. In other words, we can measure electron flow to the mitochondria. And I can assure you, many patients do very well with just a small amount of fluid. But some of those patients, you get to a great oxygen delivery, and all of a sudden, electron flow is stopping. And we have models where we can give targeted metabolic therapy and increase electron flow. Now, I'm concerned we might be creating reactive oxygen species with all those electrons. But that just suggests to me that a tailored, individualized approach could make a huge difference. And, you know, surgeons love to talk about this, about maximizing oxygen delivery after trauma. You'll hear them do this all the time. But I think we just need to have the same sort of precision in sepsis and fluids and identifying what the endpoints are and making sure whatever we decide is systematized across all patients. Because I think the bundles have done a lot of good, but we've reached the limit. I hope I answered your question. It's really important one, Pat.
Final question?
Thanks. Great talk, really inspiring. I had two questions, but we can choose to answer both. One was about this sort of transition period between a patient gets discharged, you know, so the case you shared about the 12-year-old, you know, patient at home. I feel like that's an opportunity for potentially AI and machine learning to be able to help detect patterns in even the number of times a child might pick up their cell phone, for example, could indicate they're not feeling well or feeling better. So just sort of as a missed opportunity besides just data that you collect as a snapshot from a hospital encounter. And the second piece was how can healthcare organizations like Sinai or Drexel partner with Google or OpenAI, because I know a lot of private sort of industries have better access, but academicians like myself who are delving into AI and ML really don't have that sort of door open. And of course, we have to think about patient privacy and ethical considerations, but just wanted to hear your thoughts, and again, feel free given the time pressure if you want to.
I'm not feeling, first of all, thank you for the question. Of course, I knew I'd get a sophisticated question from you. So I think the first one is really straightforward to me. What we need to do a better job of monitoring. We now have the technology. At Drexel, we have a functional fabric center. And it's interesting, they partner with the DoD and the MIT group to do functional fabrics for the military. And it's amazing what they can monitor. They can monitor heart rate, temperature. They're now doing metabolic monitoring in these clothing packets. So why aren't we using it clinically? I mean, the technology is there. You could do wireless transmission of these data. We've got, you know, cell phones that could link it to our system, and we have the analytic tools to do exactly what you suggested, is determine patterns of danger or change or whatever. So I really think we need to embrace the functional fabric movement. In fact, we had a discussion yesterday at lunch with a proposal that there would be shirts that would monitor electrocardiograms, and I'd say you could do oxygenation, temperature, respiratory rate, everything else. Frankly, we should be doing that with all late partum women, in my opinion. You know, in emergency medicine, I get to see when things go bad, and why can't we just monitor people? We have the ability to say nothing to chronic disease. So I think wearables. The second one would be, let's be proactive on those approaches. That would be consistent with the new paradigm of healthcare, right? To be proactive. I think it'd be cost effective, but it most certainly would tailor all of this to an individual. So I agree with that. And you had a third question for me. I think I missed it.
Well, it's just partnering with Google or AI. You know, to sort of
Well, you know, I think, so there are lots of answers to that question. I think Microsoft really has done extraordinary advances. I think the challenge with having a closed system, though, that isn't open access, that we don't have insight into their tools. And the second one is, and this is non-trivial, is that when you start feeding a system like that, the amount of information we did to get those knowledge graphs, yeah, it may only be like 1/10 or 1/100th of a cent per bundles of PDFs. But imagine how many PDFs I just showed you. It could easily run into millions of dollars just for a single knowledge graph. So I do think open sources are going to be important for academicians and for clinicians to move forward. Otherwise, it could become prohibitive just there. So our group is dedicated to open access. I'd love to have tools that are available. I'm going to go back to our group and bring your question back, because a lot of the discussion so far is how do we apply this to things like rare diseases? So we've been looking at, on the behest of 3 patient foundations, rare diseases. One of them is a neuromuscular disease. And there's a clinical trial, very specific. They're trying to enroll 10 patients. We went into our data sets and we were able to identify with very high certainty 256. That could be valuable. Have we linked those 2 things? Not yet, but we want to get it out to people so they understand. And for that particular disease, the average time to diagnosis from first presentation is 6 years. So I think there's a clinical imperative to get this done. And then the last piece is, yeah, we're in discussions with all those companies.
Thank you.
Go on and on.